Hi, everyone. Thank you so much for joining. We're going to give everyone a few minutes to jump on. Hi, everyone. Thank you so much for joining. We're just going to give everyone a few minutes past 1 o'clock. We have a lot of folks joining this afternoon. Hi, everyone. Thank you so much for joining. We're going to give everyone just another minute or so to jump on. I see that the numbers are slowing down a little bit, and then we'll get started today. Thank you for your patience. All right, folks. Well, it is about 1:03, so I think we will get started. This webinar is being recorded and all registrants will be emailed the link in a couple of days. So look out for that. And thank you so much for joining us today to discuss the recent CMS guidance addressing health-related social needs in Medicaid and CHIP. We are so lucky to have two expert panelists to discuss this guidance with us. We will have time at the end for audience Q&A and discussion. Please put your questions in the Q&A box so that we may be able to answer those as the questions come up at the end. As I said, if you have any technical difficulties, feel free to message us with those, and we will do our best to address those issues as they arise. So we will jump right in. As I said, we're here to address recent guidance that was released on November 16th, 2023 by the Centers for Medicare and Medicaid Services, detailing the coverage pathways for services and supports to address health-related social needs or health-related social needs services, like housing and nutrition interventions in Medicaid and the Children's Health Insurance Program, or CHIP. And this guidance really responds to growing nationwide momentum to address negative health outcomes, rising healthcare costs, and deepening disparities by incorporating health-related social needs into patient care. This guidance was released with several other documents as part of the Biden-Harris administration's action to improve health and well-being by addressing social needs, determinants of health, So today we're really fortunate to have with us Kim Prendergast, who is the Vice President of Social Health at Community Care Cooperative, or C3, which is a federally qualified health center-led accountable care organization, or ACO, based in Massachusetts. In this role, she leads the ACO's strategic and policy initiatives to support FQHCs to leverage value-based payments and address social drivers of health to improve health equity and health outcomes. Kim joined the organization in 2019 and was the architect of C3's work to build partnership across the healthcare and social services sectors, designing and implementing their $20 million flexible services program through partnerships and contracts. Today, C3 partners with more than 25 community organizations and has supported nearly 15,000 C3 members with interventions to improve food security, housing instability, and homelessness. Prior to joining C3, Kim spent 2 decades addressing food insecurity and health with Feeding America through roles in public policy, nutrition programs, and healthcare partnership consulting. Kim is a registered dietitian nutritionist with a BS in dietetics from Purdue University and a master's in public policy from the University of Chicago. She lives in the Boston area. We're so lucky to have Kim lending her perspective here today. We also have with us Dorea Walters, who's the Chief Business Development Officer at God's Love We Deliver, an agency that last year delivered more than 3.6 million nutritious, medically tailored, high-quality meals to men, women, and children living with HIV, AIDS, cancer, and other life-altering illnesses in New York City, Westchester, Nassau, and Suffolk counties, and in Hudson County, New Jersey. In this role, she is responsible for helping God's Love to identify, prospect, and navigate new business opportunities, as well as to maintain and increase current engagements and business relationships. Responsibilities include securing and establishing new engagements to build varied and sustainable revenue streams for the agency that helps God Love to serve the sickest of the sick. Prior to this role, Ms. Walters had a variety of roles within the agency, including serving as the Senior Director for Program Services, where she was responsible for all client-related programs, establishing strategic partnerships, and coordinating program-related relationships, and as the Director of Client Services, responsible for planning and designing the department's response to agency goals around mission expansion, client growth and retention, and the agency's evolution of service provision. Ms. Walters was most recently the community co-chair of the HIV Health and Human Services Planning Council of New York. Thank you both so much for joining the Center of Health Law and Policy Innovation of Harvard Law School for this amazing webinar. Kim and Dorea are going to be sharing their really diverse perspectives on the potential of on-the-ground implications for Medicaid managed care agencies, or ACOs, and Kim's unique position, community-based organizations from Dorea's unique positions, and really others just seeking to address health-related social needs like housing and food and Medicaid and CHIP. And like I said, we're going to save 15 minutes for questions at the end. Before we dive into those specifics, though, Kim, Dorea, and myself thought it'd be really helpful to provide you with a little bit more context for this guidance. So first, we really wanted to emphasize that this guidance is just part of and builds upon considerable policy support and momentum for addressing the social determinants of health and healthcare, really kind of led at the federal level. So for example, CMS recently released codes in Medicare Part B that allow for reimbursement for screening and referral for health-related social needs services. And the guidance we are talking about today really incorporates several years of guidance documents that the feds have already put out, expanding payment pathways for housing and nutrition services in Medicaid and CHIP, right? So this is kind of the culmination of a lot of work, and we kind of see it going even further than this. Second, states have been taking advantage of these federal opportunities to innovate and to help their populations on the ground. And Kim and Drea and a lot of you have been a part of that. And this guidance very much reflects the implementation learnings of those states. And you'll kind of hear about that from Kim and Drea. Finally, we're going to talk a lot about 1115 waivers today because they're the biggest. They come with infrastructure funds, which are super important, but this guidance details 4 coverage pathways: in lieu of services and settings, home and community-based service authorities, Section 1115 demonstrations, and CHIP health services initiatives, many of which, like home and community-based service authorities, nearly every state is currently operating. So there are possibilities for every state and organization in their field, kind of wherever you are in the process. So you could have takeaways from this presentation and from this guidance, kind of wherever you are, even if you don't have an 1115 waiver. Likewise with services, this guidance outlines 15 services, 10 housing services, and 5 nutrition services, from case management to education to direct provision of food and first month's rent. That can be covered under these pathways. So there's really a world of possibilities, kind of small and large, but all can have an impact for beneficiaries. So with that, what you're really waiting for, we want to open it up for a kind of moderated discussion with our lovely panelists here. And what we want to do is first kind of set the stage and context with Kim and Drea. And Drea, we'll start with you. Can you first tell us about kind of the policy context in your state? So what kind of policy levers are your states using or hoping to use to advance health-related social needs? Where is your state in achieving those goals? And actually, where do you sit in that work, right? What are you doing in terms of your organization?
Thanks, Erica. So just for context, for New York State, we are one of the biggest Medicaid providers in the country. And our state has been very innovative and, let's say, progressive in concepts and exploring new ways of providing services. But at the same time, looking at cost-efficient ways of creating the greatest impact possible. So we had a few years back experienced a waiver-like dynamic, which we call DSRIP, and it started the conversation around value-based payment for community-based organizations, innovative projects and pilots for both managed care organizations and hospitals and health systems to really explore partnering with community-based services to impact the communities that we all care about. And that was, let's say, the first phase. And then after that, there were the opportunity to create pilots around in lieu of service, which is the equivalent of a replacement of one service utilizing another service. So one of the projects that we've been involved in that's now a program is providing medically tailored meals to individuals that are dealing with a particular diagnosis, a serious illness, that also have had a certain number of hospitalizations and emergency room visits in the previous 6 to 12 months, and then having medically tailored meals provided as part of a supportive intervention, along with making sure that the individual is engaged in clinical care as a way to help managed care providers really look at managing the high costs of certain populations. So we saw that with food and nutrition. There's other samples of that in the state. And that's what we anticipate will continue to grow as more plans start to participate. And then at the same time, currently New York State Department of Health is working with CMS on an upcoming 1115 waiver. The concept of that waiver will, create even more innovation across the state, looking at housing, looking at food and nutrition services, looking at transportation as well, making sure that as many people as possible have their health managed in a more comprehensive, collaborative way, recognizing that it will require workforce support. So there are funds that are going to be supporting that through the waiver. And we're just excited for that opportunity. But I'm sure Kim has a deeper perspective on that from where she's from.
Thank you, Drea. That's really helpful to kind of see what I was talking about, that this guidance has many different pathways, right? Kind of on a spectrum in terms of, small to large impact, right? And that New York has kind of followed that trajectory, right? And is waiting to see when that 1115 waiver will actually be approved, right? And that you're kind of using that in lieu of services pathway right now. And we'll kind of talk about the plus and minuses that you've maybe experienced with that. Kim, how about you in Massachusetts? What kind of levers are you using in the state, and where is C3 kind of situated in that work?
Absolutely. Thank you. It's so great to be here with you. And I want to just say a big thank you to our state agency partners who are on the call today. I see some of our friends from Medicaid in Massachusetts, which we call Mass Health, who have been so innovative and so instrumental in making this work possible in Massachusetts. So as Erica shared, I work for Community Care Cooperative, which is an accountable care organization led by federally qualified health centers in Massachusetts. Our 1115 waiver that it first invested in health-related social needs work began in 2018 and also created the accountable care organization structure in the state, moving us in a very big way towards value-based payment. Part of that waiver created the Flexible Services Program, which launched in 2020 and gave accountable care organizations the authorization to utilize Medicaid dollars to invest in nutrition programs, in pre-tenancy interventions for members experiencing homelessness, helping with housing search and placement, as well as nutrition interventions for individuals experiencing food insecurity. Eligibility for those programs was for each of the accountable care organizations to run those programs themselves. For members who met health needs-based criteria of complex physical or behavioral health needs, high-risk pregnancy or the child of a high-risk pregnancy, members with challenges with activities of daily living, and those who are high utilizers of the emergency department. So for the last 5 years, for the last 3 years of our first waiver, and then into this new 1115 waiver, which began in 2023, we've been operating these programs. And so Community Care Cooperative, I joined the organization to lead this effort for us, and we have really invested in a variety of programs with social service partners across the state. We have 23 federally qualified health centers across Massachusetts. And so worked to really think about the ways in which we could partner with social service organizations to truly invest in community. I think because Massachusetts has been such a pioneer in this work, we've also had the opportunity to really look at what has been successful, what has been challenging, and share some of that data and those lessons learned back with CMS. And so we were so excited to see some of the guidance come out and the federal government reacting to some of the changes that they had made in policy from the first waiver that ended in 2022 to the second waiver. There were a few changes that were made in terms of the guidance and what was allowable through our 1115 waiver for flexible services, like limits on the time in which a member was allowed to receive nutrition services to 6 months. And so when we see this new guidance, we see some changes that react to the advocacy and the learnings that we shared and from other states as well. So we're really excited to see those kinds of policy changes happen.
Thank you both. That's a great transition, Kim. as we see this progression, and as we mentioned, there's been just like a lot of momentum in this space recently. A lot of that is driven by this federal policy, but a lot of it, as you mentioned, is really driven by the implementation that's happening on the ground. So what does the release of this guidance mean for your work?
Yeah, I think at its core, the release of this guidance is so exciting, not only for our work in Massachusetts and the way in which accountable care organizations are working with to address the health-related social needs of our members, but we really need to celebrate what it means across the country. When we started in Massachusetts, when Dorea's team started in New York, when California, a handful of the states that have been most innovative got started with this work, we had pretty loose guidelines from CMS, and there was a lot of work by all of our organizations in partnership with our social service organizations, which is what we call the community-based organizations in Massachusetts, really sitting down to think about what does the evidence tell us will be most effective in housing programs and in nutrition programs. How do we do this work in ways that don't duplicate SNAP and the state housing programs that we have, et cetera? And so there weren't a lot of specifics about what would work best and how to implement these programs efficiently and in a streamlined way. And so there was a lot of whiteboarding and a lot of really thinking about how to start from scratch. And so I think what's really most exciting here is that this guidance is an opportunity that CMS pulled together the best thinking thus far, the best data that has come together to be able to create some roadmaps such that as new 1115 waivers are proposed, states can really anchor on this framework and not have to start from scratch. As new implementation begins, health organizations and community-based organizations can come together and really think about how do we do this work together, as opposed to what is the work, what are the rules of the road to begin with. And I think that's really exciting, and such, this guidance moves this work forward so much more quickly. In Massachusetts, what's exciting for us is that we're seeing some adjustments to the flexible services program that's authorized through 1115 waiver already. So the guidance came out on November 16th. And last week, the state agency had already said, here are a couple of changes that can go into place. In particular, we're thinking about on the nutrition side of the programs that previously we were limited to 6 months in terms of being able to provide medically tailored meals, medically tailored groceries, produce prescriptions, healthy foods vouchers, et cetera. And the new guidance clarified that where members are still eligible, where it's still clinically indicated, that we as an ACO can make the decision to extend for another 6 months, which we think is really important because we recognize that while our programs are intended to have a short-term impact and really see behavioral changes and address food insecurity in the short term, there are many situations where we need to extend beyond that 6 months to be able to have an impact on a member's health need. Additionally, we're looking at an opportunity to extend some of those services to households where the eligible member is a child or a pregnant individual. We can provide household services. Currently, that has just been medically tailored meals. And the new guidance allowed for, and the new flexible services guidance in Massachusetts is making it a possibility that we can think about, having household services that extend to healthy food vouchers or produce prescriptions or medically tailored groceries or protein boxes. So really allowing us to think about what's most appropriate for this household, and also what will be the most effective use of our dollars.
Thanks, Kim. I think that was a really great summary kind of for all states, right? You don't have to start from scratch, right? This can feel so overwhelming, and states like Massachusetts have been the guinea pigs, right? And organizations like Kim's have been the guinea pigs for you and done these learnings. And this guidance very much reflects that. So this is a good template. And she highlighted some amazing changes that have happened. And yes, shout out to the Massachusetts Mass Health folks that are on the line, right? Putting out that guidance already, implementing making some of those changes, like the 6-month renewal and some of those household changes for the populations. So Drea, from your perspective, kind of same question, right? What does this guidance mean for you, for other CBOs, kind of on the ground, moving forward, and also in a state that's in a little bit different of a position, right? You don't have a waiver yet, you're using different flexibilities.
Thanks, Erica. So for New York, right, God's Love, full transparency, provides medically tailored meals, but partners across the spectrum of food is medicine. So that means providers that are providing SNAP or the gamut of everything that you heard Kim mention. For New York, their process has been, I think you can call it, they're building the momentum and making sure that all of that exists when they are indeed able to finalize those conversations around the waiver for CMS. I think they, in the pilot creation of their in lieu of service innovations, especially as it relates to providing medically tailored meals, have been able to see enough data that has justified to our Department of Health to really kind of be in line with CMS's vision of course, someone has to potentially be reauthorized in the event that they are dealing with a more severe illness. And that is in line with the way that managed care organizations normally do their work, with care management, social work, et cetera, making sure that there is a screening of some kind to reassess what is going on with the individuals. The fact that nutritional counseling and education, medical nutrition therapy as part of that plan of care is really something that then supports both educating the individual as well as the whole family. So I think that's really exciting. We're seeing that with New York, at least for the pilot phase, had concentrated on diagnoses such as HIV and AIDS, cancer, and severe diabetes and congestive heart failure, and now are open to exploring additional diagnoses. And I think that's mirroring CMS's vision to really kind of understand that the landscape of what's going on with healthcare is evolving, and it requires collaboration with providers that are out in the communities, right? Once someone is discharged from the hospital, their support needs to continue in slightly different ways. So really allowing for that collaboration and encouraging that. So I think that's really exciting as well.
Thank you so much, Drea. Can you say a little bit about like how maybe your clients and the other folks that you're working with are kind of reacting to these changes also?
Yeah, I mean, I think it's been exciting to work with our partners and our clients at the same time, right? It's all about messaging. We are the last leg of the experience. We are arriving at the home and are able to speak to the clients that we serve. They are excited at the fact that they are able to see their illnesses improve. They're able to better manage their medications because they have something to eat while taking these medications, whether it be chemo or radiation or other kinds of medications and treatments. The other thing is it's causing less stress for the family. We do have some partnerships that are really looking at the whole family, children, as Kim had mentioned, and expectant parents as well. So I do think that this is something that the community is appreciative for and excited to participate in. And we understand from an administrative perspective, but also from a client perspective, that it's not a forever program, right? That is not its intention. Its intention is to help stabilize and then to help someone be as well as possible as they continue with their lives, right? And overall, hopefully, whatever illness that they were dealing with has been significantly improved, and now they have more information and understanding as to how to manage their health moving forward.
That's great, Drea. Thank you so much, both of you. So following up on that question, is there anything that you think the policy guidance left unaddressed or that needs further clarification? Kim, we'll start with you.
I don't know if there's anything that it left unaddressed, but I think it's important to remember that this guidance is for Medicaid and CHIP. And so, this is how Medicaid and CHIP dollars are used as part of our healthcare system's approach to address health-related social needs. And so, I think at its core, it's amazing that, we're able to really, as a country, address social health needs as part of our behavioral health and physical health needs as well. And so the integration of social health and with social services integration is how we describe it in Massachusetts. It's terrific. I think what we see across the country is different ways in which these kinds of programs are implemented. And so reminding ourselves that we need to keep our providers, that we need to keep clinicians, we need to keep the clinical services in the mix is very important. So addressing food insecurity as part of diabetes control means that we need to also be sure we're thinking about how is, in my case, the Federally Qualified Health Center involved in that information, and so that the providers know that the members are receiving these services, that we're thinking about addressing home modification needs, addressing homelessness with the provider, especially as we're thinking about, a patient is moving, a patient has these needs, and that we don't separate these services and merely have an accountable care organization, a managed care organization, kind of thinking about, who might be eligible? How do we do this in the most efficient way? But how do we really drive toward having these partnerships be really meaningful for the patient, the member? And then I think the other side of that is, as we work to expand these programs and ensure that we're serving enough patients, also investing the time in truly working with community-based organizations. And I'll just say hello to some of my community-based partners who I also see on the call. But we've worked very intentionally to try to understand the communities in which each of our health centers are providing services, and how do we assure that we're finding community organizations who understand the needs of those members, understand the Boston area versus the North Shore of Massachusetts versus Western Massachusetts, because they're very different parts of the state. Assure that we're working with community-based organizations who have staff who look like our members, who speak their languages, who share their cultures, and so that we're really able to integrate all this work in a meaningful way. So while those aren't guidance items that I think CMS is going to put out at this point, I think those are lessons that we've learned that are really important for us to keep in mind in terms of what has made these programs really successful thus far.
Great points, Kim. So I think keeping in line with remembering who your partners are, right? Providers and CPOs. Dorea, what's your take? Is there anything that the guidance left out or that you think needs further clarification?
Yeah, thanks, Erica. I think just following up with what Kim said, it's about really looking at health equity and cultural responsiveness, and how can that be addressed and handled in the most honorable way for the communities we're all trying to serve. So that's where I think partnering with community-based organizations is a way for healthcare, right? Clinicians, managed care providers, all of it, to be able to then really look at innovative ways to impact the communities that we're all trying to serve. And the models can look different depending on the communities, and they should look different, right? Nothing should be cookie cutter, understanding that, this is an innovative opportunity to really look at all kinds of communities. Yes, of course, needing these services, but they may need to be provided and presented in different ways. And of course, echoing what Kim said, partnership is key. Relationship building is essential to be successful in these kinds of endeavors. At God's love, we're so excited to be partnered with some of our insurance partners that are on the call as well. And those discussions have been clear and candid, really looking at the data. Who are the populations that we can start to serve? What are the nuances of serving them? And then making sure we bring in other types of community-based organizations that perhaps do housing or perhaps do, substance use support care, whatever that is, so that we're all concentrating in a collaborative way to provide holistic, right, engagement and care for these individuals, right? We're all talking often about closed loop referrals. We should know that a service has been provided and where the warm handoff is so that we can encourage people to remain engaged in clinical care. And all of that is from the lens of health equity, right? And how to do that together. It cannot be a siloed effort. And I don't think CMS believes that, but there's a way to further encourage that.
Thank you, Daria. I think that's a great sentiment. And you all are kind of bringing it back to like it comes down to implementation, right? So this guidance details, right, these 4 different payment pathways, and there's ways that they differ in terms of their scope. And I linked to the guidance and the nice matrix that CMS kind of laid out in terms of those 15 services and how they differ for payment pathways. And I know we're not getting into those details there. We can answer more in the questions, but I think what you all are getting to is like what it comes down to are the partnerships, right? And how those are all structured once your state decides to kind of go for this, right? Prioritize health-related social needs and make sure that you're prioritizing health equity and community focus and things like that. And I think that's really important to keep in mind as we move forward. So speaking of, Drea, we'll start with you. Where do you see kind of your work and maybe all of this work going from here in terms of furthering health-related social needs now that we have this guidance and everything that's happening in this space?
Yeah, I think so. At God's Love, we're super excited by this new guidance. I think it furthers the essential nature for community-based organizations to collaborate together, but also with local healthcare providers to really start conversations if they have not started already. Many have already started, at least for New York State. We're seeing lots of, let's say, collectives and collaboratives around service provision really popping up across the state. And that's fantastic. But at the same time, there's got to be that cross collaboration and pollination of efforts, and what can that look like? And I think for New York State, we have a team at the Department of Health that is really interested in encouraging that collaboration to be in place prior to the waiver being approved for us. And I think that's something that I would encourage anyone across the country to really be looking at. But it's all about, like, this is the brick and mortar. The work continues, being clear about what you do well as a community-based organization. If you know that you could collaborate with another organization, do that. What does partnership look like through business associate agreements, memorandums of understanding, et cetera, but really thinking about the whole individual rather than just through the lens of your specific service.
Thank you, Daria. Kim, same question. Where do we go from here?
I agree with Daria, and then I think I'm looking at some of the questions that are coming up, and I think our participants see where this is headed as well. We often talk in Massachusetts about our original flexible services program as being a grant-funded program, and I think what we're seeing now, both in Medicaid and in Medicare, is moving this work more, to be even more integral into the healthcare system. So the new physician fee schedule allows for reimbursement for providers for conducting health-related social needs screening, for community health workers and others on the care team to be able to start addressing some of those needs. So the Medicare new physician fee schedule is really just thinking about the services that can be provided at the clinical setting or in partnership where community-based organizations are really clinically integrated in addressing some of those needs. And then we're starting to move toward, in Massachusetts, a version of the flexible services program or our new health-related social needs framework where health-related social needs providers will be tied even more closely to the accountable care organizations or a third-party administrator in some of our cases. And so starting to actually bill for services and putting a lot more standardization around this work, which I think is really exciting. And also the next frontier of, I see some questions about what are the codes and what are the rates. I think in Medicaid, what we're seeing right now is rates look a little bit different in different parts of the country, because we recognize that what meal service looks like, the cost of goods, the cost of staff time, the cost of delivery in different places might be different. But beginning to standardize the approach. And so what are the services? What should those look like? What does nutrition education look like? What does housing navigation look like? What should we provide in terms of numbers of meals and things? And so a lot more effort to conduct this work in ways that then we can count administrative data capture in the healthcare sector and allow us to really understand, are we making a difference for some of these patients? And then I think I'm just looking at some of the questions to see, and then we can talk about those
They're great questions.
There are great questions. In general, I think moving forward, it's just so exciting as someone who's worked in food insecurity for a long time, worked in the social service sector, and then came into the accountable care world. As we strive to address health equity and improve health outcomes for our patients, and really think about the shift towards value-based care, I'm so thrilled that CMS is driving into a direction, and our Medicaid agencies are driving into a direction where we're really integrating social services and health-related social needs care into our work. And so that is just, I think as we consider the future, this is a place where we're really considering the well-being and the holistic nature of our patients and how we provide care. And so that's really exciting.
Well, thank you both for digesting this guidance so quickly and for your wonderful insights and all the work that you've done up into this point and moving this space forward. And I know so many of our participants have done that as well. So we have some great questions. I think the first one that I want to start with is, for folks who are in states who haven't even started this process, what is the first move? What would you suggest for folks?
Yeah, I can start, and then we'd love to hear what Daria has to say too. I think the first, so in thinking about what's right for a state, is it an 1115 waiver? Is it a different version of these policy mechanisms? I think the first step is to really have conversations with your Medicaid agency and share, from whatever vantage point you sit at, if you're a community-based organization, if you're a healthcare provider, if you're an accountable care organization or an MCO, really sharing what you think is possible and learning about what's happening in other states that look like yours and being able to bring that enthusiasm. I think where a Medicaid agency thinks that this is going to be successful, then there's more opportunity to move forward. And what's great is that this guidance provides a lot of the skeleton of what an 1115 waiver or an in lieu of services can look like. But being there to start to talk about some of the implementation considerations in your state is probably really necessary. And I think we see across the country lots of great opportunities for organizations to share their experiences with similar organizations in other states. And so, Daria can talk about the Food as Medicine Coalition and some of that kind of work where we're hearing about examples in really tangible ways.
Yeah, Kim, agree with everything you said. I think it's imperative that both community-based organizations and, clinical providers, MCOs, start talking to your Medicaid provider, your local Department of Health, and have those conversations. From an advocacy perspective, that's what the Food as Medicine Coalition has done, gathering all providers from across the country to be able to talk to elected officials as well as to your departments of health. This is what healthcare can look like. How do we get there, right? And bringing the right people to the table to really start those conversations. And I think the other thing to also keep in mind is innovation requires a boldness of effort and intention. And it's not that everything will be laid out in a perfect way, but if there are partners that are willing to really explore how to lower the overall cost of care and create a greater impact on the members they're providing services to, then, you have the right initial ingredients to kind of move the needle. And those are the players that will pilot something or can, be the initial participants in a program that is a little different looking than what we've seen for the past 30 to 50 years.
Erica, you're on mute.
Sorry about that. I think this is my first time on Zoom. I think this is a really great question, and we get this asked a lot. So can you all clarify how your organizations or generally how you've seen this done ensure that there's not a duplication of other available social services for Medicaid members? So things like SNAP assistance, HUD, housing services, things like that.
Yeah, great question. We talk about it all the time. And so I think, the most important way to ensure that there's non-duplication is to make sure that everyone who's involved understands what all of the other benefit programs might be and that we're asking about and we're cross-checking along the way. And so importantly, we're considering the supplemental nutrition assistance program and making sure that our members are receiving those services before we make a referral into flexible services. And so it's one of the questions that we ask as part of the referral in. We're making sure that then our health centers are aware of housing programs. And we also spend a lot of time talking with our community-based organization partners about duplicating that conversation and making sure that, they're asking about SNAP. If we had started a process of applying for SNAP, what happened, and can they follow up if maybe that fell through the cracks? The meal providers are making sure that for the members who are between the ages of 60 and 64, if there's another way that can get paid for, that's happening. We have an additional housing program in Massachusetts that's a state-funded program called the Rental Assistance for Families in Transition, or RAFT. And so all of our housing organizations are really thinking about what's possible here. And then we've even worked with one of our organizations. We have another program in Massachusetts called the Community Support Program that can provide some housing supports. So we're cross-checking those lists to be sure that members are getting the right program first. And I think part of this, again, working with community organizations, there's so much effort to be sure that at the heart, members know what is available to them. And so that we're really not just saying, oh, you're eligible for flex or you're not, but really thinking about how is it that they understand the programs that they might be participating in and how to best utilize all of those benefits for the supports that they need.
And I think I would just add to that, Erica, and Kim, that technology is the future. And I think there will be states that will be incorporating, let's say, systems where all kinds of providers are able to see what kinds of services people are receiving. And at the same time, it will likely up the ante for community-based organizations to really start to create a mechanism for checks and balances as to ensure that there's no kind of overlap. Or at the same time, you want to have at the ready, right? Like if everyone's eligible for SNAP, wonderful. If someone's on medically tailored groceries, great. Something shifted, they were hospitalized. Now they move to medically tailored meals. Once that ends, does it continue? No, back to groceries. We should be able to see that trajectory as providers, but then also our local, department, states of health should be able to see that as well.
That's such a great point. And I see there's a couple of questions about supports for community-based organizations. And so just following up on that IT conversation, and I think one of the things that you see, this is in the guidance and in the CHLPI summary, but states are allowed to include administrative dollars. And in fact, many states have buckets of funds that they have set aside just to particularly support capacity building in the community-based organizations. And so, such an important part of this work is assuring that community-based organizations are ready to be good partners, are ready to take on these different approaches. including support for IT, of support for additional staff. In our organization, we created a platform that is how we make referrals into our flexible services program from our community health workers and others at the health centers. And then the social service organizations also use that. It means we've done a lot of training, but it also meant that the social service organizations had to either use that system or they could build an API interface to whatever system they were using currently. And so those dollars could be used to build those systems and really allow everyone to work in as streamlined a way as possible.
I think it's great to really emphasize those infrastructure funds that are only available under 1115 waivers. And so that's another reason why we talk a lot about them, and why a lot of states have been utilizing those. And on the kind of SNAP HUD, all those duplication questions, I will just add that in the guidance and in all of the 1115 waivers that you see, it's actually a requirement for the Medicaid agencies, for the states, to make sure that that duplication isn't happening and to actually strengthen those other social services programs. So to try to make sure that everyone who's eligible for SNAP, for HUD rental assistance programs, for TANF, WIC, those programs are getting enrolled if they're eligible. And so a lot of that is on the state. And so what Dorea said, you know, they're trying to increase their coordination and their technology. So it doesn't all fall right on the organization. Yeah. States are really trying to improve sometimes ancient technologies. And so those are things that are being improved kind of across the board, and there's support for that.
I can just actually add two more quick things. One great example of coordination, a couple of years ago in Massachusetts, the Mass Health worked with the Department of Transitional Assistance and sent all of the accountable care organizations a list of members who were likely eligible for SNAP who weren't receiving SNAP. And so thinking about that SNAP gap was a great opportunity for us to consider how is it that we can, you know, work to do some outreach and help our health centers and then, you know, the other ACOs, other providers to assure that we're making referrals in those situations. And then for us, we've also done a lot of additional training with our health centers to make sure that those staff are aware of and know how to make referrals to SNAP and the RAF program and utility needs, you know, so all of those, making this a much bigger approach to addressing health-related social needs, so that folks know all of these steps should go into place before a referral into flexible services.
So a lot of the questions have asked, right, this new guidance has clarified a lot of things, particularly for household level supports for pregnant individuals, their households and high-risk children, for allowing reauthorizations after 6 months. And do states that already have these services under, say, 1115 demonstrations then need to reapply for changes? So Kim, I'm interested in your experience, you know, when you received the new guidance from Massachusetts, how did they go about that process of updating you on those changes?
So there's a lot of communication, which has been great. We have annual guidance that comes out that provides a really comprehensive look at this is what's allowable. And then they do this fantastic job of sharing all of the changes each year, so that we know this is what we need to think about that's different. And then there's been a lot of communication along the way, which means, you know, so when they made the changes just recently, that was through an email with here's the breakdown of the new opportunities that are allowable, you know, effective immediately, what's effective in 2024, et cetera. So this, and I suspect that this is the case in most states, there's a lot of communication that gets pushed out. And then there are also opportunities where the state will host a forum. And so there's an opportunity to, you know, to listen and hear about new changes in the guidance, new approaches, opportunity to ask questions. And it's really been a nice relationship where we're able to share ideas, ask questions. You know, every time we have new data that we're excited to share, we'll share that with the state. And I think that it's made for a really collaborative opportunity to address the needs of our members together.
Drea, do you have anything you'd like to add to that?
I'm processing. There's so many questions. I think what Kim said was great. And I'm trying to answer some of the questions in type as well. So keep going, Erica.
I love all of the questions. It's really great. Yeah, I'll just add that kind of ultimately the state will need to communicate with CMS on whether or not there needs to be kind of an official update to the waiver based on this guidance. But certainly as stakeholders, you should be communicating with your Medicaid agency, like Kim is talking about, right? About whether, you know, there are planned updates in terms of guidance or whether that further communication with CMS needs to happen. But it's good to know, right, about this guidance and kind of what's going on in your individual states. So I know that you all are like looking through the questions. Are there particular ones that you're itching to answer live? I know you're typing answers as well.
Well, I think there's one about CMS providing technical assistance. And yes, lots of technical assistance. And I think that at the same time, it's important for a CBO, this is just my take, to remain engaged with your local Medicaid provider, your Department of Health, to really kind of keep your finger on the pulse of what are conversations and making yourself available for any questions they may have. Because on the ground, let's say organizations doing the work with these communities may have insights that, let's say, high-level administrators really can't see because they're so far away from the detail of it. So that's something else to really think about.
There's a question here about, you know, working to educate clinicians. And, you know, I think one of the, with the program that we run, you know, my organization is an accountable care organization working with federally qualified health centers. And so some of the patients receiving care from the health center are Medicaid patients who are eligible for flexible services in our case, whereas others are Medicare patients, or they have commercial insurance, or they're uninsured. And so as we move forward with these kinds of programs, what's allowable under Medicaid, what's allowable under Medicare, there's a lot of nuances to how you make these referrals. So in our situation, we've really worked to think about what are the referral pathways that make the most sense. We have care management programs. We have a community partner program that specifically focuses on behavioral health. We have transitions of care programs working with patients who are in the hospital and coming out of the hospital who might be appropriate for medically tailored meals. So really trying to think about those pathways that will identify the individuals who can really benefit the most from these kinds of investments and programs, and also not put a provider in the position of having to say, oh, you're experiencing food insecurity, we have this great program. Oops, you're not available for that one, or eligible. So it really puts an important responsibility on, in our case, the accountable care organization and MCO, you know, whoever is administering that program, to be really thoughtful about what are the workflows and who are the people who will be administering these programs, to make sure that we set them up to be most successful and really target the individuals who are going to benefit and who will be eligible.
I think we have time for one last question. I know that there's so many good ones in the chat here. Is there anyone that you are dying to answer?
I think, why don't we try to concentrate on what data has made a large impact in winning over the state Medicaid office for Massachusetts and New York to align with HRSN services support, coming from a state that doesn't really have a lot of food as medicine review data infrastructure just yet. Well, it's super interesting because for New York, a lot of the responses we would have gotten or have gotten years ago was, that's wonderful that that data exists in other parts of the country. We need to see it proven for New York-based individuals. And that's not always easy to achieve, and it takes too long because people are sick now and are hungry now. So how to kind of leverage opportunities where a pilot can be part of, a particular legislation. Let's look at innovation with particular managed care organizations or hospital systems and really evaluate the outcome. What was the state of those individuals 6 to 12 months prior? And then this intervention that has been provided, what was different? And if it's so much better, helping to message that to your state, legislatures and your departments of health. That was my take. Kim.
Yeah, absolutely. And I think, there's so much data to be tracked, and whatever data your organization can add to the tracking is important. So for community-based organizations, understanding, did we improve housing status? Did we improve nutrition? Did we improve nutrition security and food security? Did we improve a member's self-reported health outcomes? Those are great pieces of the puzzle that a community-based organization can track, whereas an accountable care organization like mine, we're looking at, did we improve diabetes outcomes? Did we improve blood pressure outcomes, et cetera? And so putting that whole story together is really valuable when we can pull it together. And I think what's great is that CMS is responding to some data from different parts of the country and not waiting until we have 50 states worth of evaluation. And then I think, I think we see a lot of questions here about where do I find information? How do I, what's really phenomenal is that, so I'm going to say CHLPI's website has great information about what's happening across the country. And we are really early in this. This guidance came out from CMS just a couple of weeks ago. And so I think we're going to start to see lots more information coming out, but in particular, really just following CHLPI, following what's happening in some of the states like Massachusetts, New York, California, North Carolina, Oregon. So there's so much happening out there, and looking to those examples is my recommendation to you.
Well, thank you so much, Kim and Drea. I think this was so informative, and thank you all so much for joining. I'm sorry we didn't get to all of the wonderful questions, but they were fabulous. We will send a recording of this presentation as well as our summary of the guidance, and I hope you all have a wonderful rest of your day. See you later.
Thanks, everyone. Happy holidays.
Happy holidays. Thanks for the opportunity.